Medurstand, Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we are going to discuss about the radiological findings of pleural effusion. Pleural effusion is actually a very common condition, and there are various causes and there are various types, and there are various imaging techniques that we can use to pick up this very important condition. So I will go through very briefly, obviously, uh, about the various radiological appearances. And this module is primarily focused on radiology, so I'll be mostly covering radiological part. The clinical parts will be covered in a separate video. Now, before we see the radiological appearances, this is just a cartoon, a drawing, which can show you what type of shapes pleural fluid can take when it accumulates. What is pleural effusion, by the way? Normally, there is a very small amount of fluid in the pleura, which is just enough to keep both the surfaces wet, so that when there is expansion of lung, when we breathe, there is no friction between two layers of pleura. But when there is excessive fluid due to whatever reason, and that accumulate in the pleural space, and mostly it will take the most dependent part, and that is called pleural effusion. So abnormal amount of fluid present in the pleural space, usually in the dependent part, but it could be actually anywhere. So that would be called pleural effusion. And there are various radiological appearances. One is called classical, and that means that mostly this is the appearance we will see. But then there's something called subpulmonic, encysted, and lamellar and mediastinal. In this slide, I'm going to show you what I mean by them, but then in subsequent actual X-rays, I will show you the real images. So what is subclassical? It will be like this. This is diaphragm covering liver, and this is the free space, and this fluid has taken up this dependent part of the right lung and obliterating costophrenic angle, cardiophrenic angle, and a classical curvy linear border, which I'm going to discuss further in subsequent slides. So this is the most classical appearance. Then subpulmonic is fluid which is under the lung, but of course above the diaphragm. So above diaphragm, but under the diaphragmatic pleura, so that it does not impress you as pleural effusion. It appears as if the diaphragm is elevated, and this is called subpulmonic effusion. Then we have encysted effusion. That means instead of being fluid being free, it is encysted, and this is usually due to some inflammatory condition, and it could be encysted against the chest wall, against mediastinum, or in the transinterstitial as shown in this cartoon. Then we have lamellar pleural effusion. Normally, pleural effusion, I just showed the classical appearance, but in some time, the fluid rises along the lateral chest wall. Now, what is the physics or what is the mechanism? I don't really understand. But this fluid is actually free, and if you change the posture of the patient, this fluid will take a different shape. Then similarly, like lamellar effusion, there could be lamellar effusion along the mediastinum. So there are various appearances of pleural effusion, and I will be mostly focusing on classical because that is what we are going to see. And this could be unilateral, bilateral, small, moderate, large. So I think that is the things we are going to discuss. All right. So this is the X-ray chest, and I understand you have attended my first module on X-ray, that was on normal X-ray. So I understand you all know what do you think is the abnormality here. And my teaching is that once you read the X-ray to yourself, I mean, you don't have to read it loud. Maybe you just go through everything and just making sure that everything is okay, and then come to the abnormality, which may be very obvious or which may be subtle, and then describe that opacity. Now, in radiology, we don't jump to the diagnosis straight away. You first describe what you see, then you give a radiological diagnosis, and then you may try to give a clinical diagnosis, especially if you know the history. So what is this? This is the cursor place. This is an opacity. Compare it to the opposite side. This is normal aerated lung with the left diaphragm, but here you don't see right diaphragm, and this is large opacity, and it is homogeneous. That means we don't see any lung markings. So that means whatever this is, it has replaced the lung. Lung has collapsed toward the normal hilum side. So there is an opacity. This opacity is homogeneous, and it is obliterating right cardiophrenic angle, right costophrenic angle, right cardiophrenic angle, diaphragm, and the right cardiac border. So all are actually not visible because this opacity is so dense, it has got like merged into the neighboring structures shadows. And the upper border is classical curvilinear. See, I'm to follow this cursor. This is the classical curvilinear line, and this is called meniscus sign. And it is usually like curved. Both sides are higher up, and then the middle is like, this is the dependent part. This is more important. So I think this type of opacity is very suggestive of pleural effusion. So I think after describing this abnormality, you say that this opacity appears to be pleural effusion, and then the examiner might ask if it is cardiac failure or nephrotic syndrome or tuberculosis. I think then you can discuss the first differential diagnosis. Once you have seen pleural effusion, the second thing is you see the position of the midline structures. If the effusion is large, it is likely to push the midline structure, the trachea and the heart, to the opposite side. I don't see much shift because left cardiac border appears to be in its normal position. Trachea is also central, so there is no significant shift. This is the prominent descending aorta. Of course, this is normal. So I think I would conclude by saying there's a large homogeneous opacity on the right side, which has obliterated right costophrenic, right cardiophrenic angles. Diaphragmatic outline is not visible. Right cardiac border is also not visible, and there is classical curvilinear up border. The rest of the lungs are normal, and there is no evidence of mediastinal shift to the opposite side. So this effusion is could be due to any cause. I think in our country, tuberculosis remains the commonest cause. So I would suspect that also, and maybe malignancy, maybe parapneumonic effusion, and I'll go through the causes also. I hope this was easy. Now let's move on to the next X-ray. What do you see? Is it the same, similar? More or less, yes, it is similar. It is again a uniform homogeneous opacity, and it has also obliterated costophrenic and cardiophrenic angles, and you don't see the right hemidiaphragm, and you don't see the right cardiac border also here. But the difference is, there are two differences, and let me see if you can figure out. What about the upper border? It's not curvilinear. It is absolutely straight and very, very sharp. Very straight and very sharp, razor sharp upper border. So I think if you see this kind of upper border, you should suspect either there is pleural effusion with some additional pathology, which I'm going to just tell you, or it may be sometimes pneumonia, because pneumonia, the border is made by the transverse fissure, that may also cause sharp border. In this case, I think if you see this part, if you compare the part where my cursor is with this part, so this part does not show any lung markings at all. And if you consider it further, and this is indicated by the arrowhead also, there is a very, very thin, sharp line going up. So this is actually pleura. So if this is pleura, something outside the pleura has to be air. It's a free air. It is not effusion, it is air, because air casts black shadow and fluid casts white shadow. So this is air. So I think the best description of this X-ray would be hydropneumothorax. Hydro refers to the fluid, and Nemo refers to this air. So this air could be and fluid could be due to some common pathology like road traffic accident, or it could be a result of some procedure like pleural tap or some surgery. And in this case, I do see, I think there is some impression that the midline structures are slightly pushed to the opposite side. So I think that's at least the heart, trachea appears to be in its normal position. So the diagnosis in this X-ray is moderate hydropneumothorax. Now let's move on. This one is just like the first X-ray. There is opacity on the right side with all the features. I'm not going to repeat. You see all the features and the typical border. And this is just for the revision and midline trachea, and you see the normal bifurcation and normal cardiac border. And please note down that the opposite side is absolutely clean. You see absolutely sharp costophrenic and cardiophrenic angles, and diaphragmatic lining is absolutely clear. So it is strictly unilateral pleural effusion, and it is free effusion because it has taken up the most dependent part. You don't see diaphragm or the right heart border, and there is no air here. So this is right-sided pleural effusion. This one is same, but this time the effusion is on the left side. Pleural effusion could be bilateral or unilateral. If it is unilateral, somehow it tends to be more common on the right side, but of course a unilateral pleural effusion can be on the left side also. If you see this X-ray, there is much bigger opacity just like the previous one, but this opacity is very much like those one because it is homogeneous. There is no costophrenic angle, there is no cardiophrenic angle somewhere here. There is a classical curvilinear border. You don't see lung markings here, and this is normal lung. But the difference is that it is bigger than the previous one, and it has, I think, pushed the midline structure to the opposite side. If you see the heart, right cardiac border, normally it coincides with the right sternal border, and this is the spine. I think it has gone way to the right side. I think fairly this much is significant shift. And if you see the trachea, this is the midline trachea, but if you continue to follow it, and the lower part is actually shifted or deviated to the right, this one. So there is a large effusion which is pushing the mediastinal structure to the opposite side, and whenever there is a large effusion, there is a suspicion of malignancy. Of course, tuberculosis can also be large, but if there is effusion which is taking up almost the complete one side, that is almost certainly malignant. Now same here, I think this is a different X-ray, not the same one, because here you see the tracheal configuration is different. This one is slightly smaller than this one. So both are pleural effusion on the left side, moderate to large. What about this? Is this pleural effusion? You see the classical finding costophrenic angle. This one is normal. This one cardiophrenic angle is normal. You see diaphragm, you see right cardiac border, and you don't see any opacity here. So there is no pleural effusion, at least on the right side. And if you see on the right side, left side, there appears to be normal costophrenic angle, and there appears to be normal cardiophrenic angle, and this appears to be normal diaphragm, but actually that is not the case. If you think that this is the diaphragm, what is this bubble? This black bubble is actually gas in the stomach, and gas in the stomach takes the highest part, and this is the highest part, and highest part is just below the diaphragm. And if you can appreciate, I can appreciate on this screen, I'm not sure if you can appreciate, there is a thick line going this way. This is actually the diaphragm. So if this is the diaphragm, this is air under the diaphragm in the stomach, and what is then this thick? This can't be diaphragm. This is actually what we call subpulmonic effusion. This is subpulmonic effusion because it is above diaphragm, below the diaphragmatic pleura, or between two layers of pleura, below lung at least. Now let's see this one. There is a rounded opacity in the right side, touching the chest wall, with smooth outline with homogeneous structure. This one is less thick as compared to this one, maybe because of the, if it is effusion, of course that will take the dependent part within that encysted, within that cyst, but costophrenic and cardiophrenic angles are cleared and the right hemidiaphragm is clear. So there appears to be large rounded opacity. This could be an encysted effusion or this could be a solid tumor. I know that this is encysted effusion because if you do a CT scan, that will tell you, or if you do ultrasound, that will confirm, or if you do what is called lateral decubitus X-ray, you ask a patient to lie on the right side and then take the X-ray. If this is fluid, it will redistribute itself along the wall. But of course, if it is completely encysted from all sides, it might maintain its present shape. CT scan and ultrasound is going to be great. This is the other side, the other person, and this is, of course, you can see that this is another person from the breast shadow. This is a woman, and this is an opacity here. It is probably encysted effusion in the transverse fissure. And if you know the anatomy, I think in the first X-ray I showed you the anatomy. Maybe I'm going to show you later. So this is the path of the oblique fissure, and this is the transverse fissure. So in the middle is the middle lobe. So in the transverse fissure, maybe there is encysted effusion. So encysted effusion, I think I'm going to show you another more common types of encysted effusion. This one, when effusion is encysted against the chest wall. So this X-ray may not be of great quality, but you see this opacity. This is actually pleura. It is lifted off from the chest wall, goes this way, and then comes down. So this is fluid which is encysted and which is attached to the chest wall. This could be tuberculosis, this could be a complication of a pneumonia or empyema, or that we can speculate or we can find out from the history. But on X-ray, this appears to be an encysted effusion against the left chest wall. This side is clear. What do you see? Is this pleural effusion? If this is pleural effusion, is it so big that it has taken up the whole hemithorax? And if that is true, do you think there is proportionate shift of midline structure? Midline structures, they actually appear to be almost normal, maybe slightly shifted, the heart may be slightly shifted, but not much. Trachea is normal. So what is this? Is this pleural effusion? Do you see the classical finding, the meniscus sign? You know, you don't see. This is actually pleural effusion. Patient is lying flat on his or her back. And this is APA film, the supine film, as you can see from here also. So patient may be very sick, is unable to stand up, and if you do the X-ray, because in supine position, the fluid tends to redistribute along the posterior chest wall. So it will take the entire posterior wall. There is lung floating in front of that. So you see pleural effusion with superimposed normal aerated lung, and this is the kind of opacity you see. I think this may be slightly difficult. Of course, you can consider other possibilities of large unilateral opacities, but I know that this is fluid because this is supine and it has taken the entire side, and you don't see the costophrenic and cardiophrenic angles, and diaphragm is not visible. So this is a large pleural effusion, but it is the X-ray in supine position. This is what I actually referred to earlier, the lateral decubitus view, and this is a patient lying on his left side, right? And if there is encysted effusion, and if you do the X-ray on the lateral side, patient is lying on the left side. This is left decubitus. It's not left lateral, it is left decubitus X-ray. It is actually PA film, but patient is lying. So this is the fluid. It has taken the most dependent part, which in this case is this one. And you can figure out that this patient had undergone some surgery. You can see these metal stitches. This patient must have undergone some chest surgery or heart surgery, and this is pleural effusion. So if you have doubt about the diagnosis of encysted effusion, you can take this lateral decubitus view. This is another example of encysted effusion. There are two X-rays and two the same person. You can see these metallic stitches on this side. This is the ECG electrode, and don't be confused, these are not actually coin shadows, these are ECG electrodes. And this is the effusion, a rounded opacity, which could be a solid structure or it could be actually encysted effusion. I think it is encysted effusion because there is some effusion here also. This is encysted and there is some free effusion here also. Here, I think there may be some problem with the chest cage. Maybe this patient had trauma or something, but this is effusion and this is encysted effusion on the right side, and you see the metallic stitches. On the left side, the encysted effusion, the transverse fissure. On the left side, you see the same, but you see encysted effusion in oblique fissure. On the left side, we don't have a transverse fissure. So there appears to be two cysts, this one and then this one. This one is more classical. See, this is pleura coming and the fissure, and one layer going this way, the other layer going this way, and in between there is fluid accumulation. So this is encysted effusion. If you have this kind of appearance, there should be no doubt about the diagnosis. Let's move further. What about this one? Do you see any problem here? Actually, this is a module on just X-ray and the pleural effusion, right? So just focus on that. What about this one? Is this side clear? Yes. This side, I think there is fluid, but you see it has gone sort of risen this way. If you compare this wall, see this one, there's a fluid which is rising up. So this may be, and patient is erect, it's not a decubitus view. So in upright position, in a normal person, fluid should have taken this side, this shape. But in this case, there is definite obliteration of right costophrenic angle, and you can see this lamella of effusion going up. So this is lamellar pleural effusion. Despite all this, X-ray remains relatively, as compared to other tests, which I'm going to show you also, like as compared to CT scan and ultrasound, X-ray picks up effusion only when it is significant amount, because in the PA film it has to be I think at least 100 ml. But you can pick it up earlier if you see the lateral X-ray. And this type of effusion, I would probably like to do a lateral film to be sure that this is actually pleural effusion. Let me see what the lateral film shows in this patient. If you see this kind of thing, and this, see, this is the part which shows pleural effusion. If in a normal person, in a PA film, this is the most dependent part. In a PA film, the cursor shows the most dependent part on the right side, and this is the most dependent part on the left side. So if there is fluid, it should come here and obliterate these angles. But if you see the lateral film, now compare it with this one or this one, the most dependent part of the pleura is actually this part, the posterior recess. So small amount of effusion is more likely to show in the lateral film obliterating this angle. This is, I think, also, I'm not sure what should this be called, this diaphragmatic, I think costophrenic, the posterior side angle. So this is the place. So I think fluid has to rise to above this line to be able to be visible on PA film, but only this much fluid is visible on the lateral film. So this is only to emphasize that the lateral film is more sensitive. So if you suspect pleural effusion and PA film has not shown, you could either go for an ultrasound or you could go for a lateral film on that side, and that might show the fluid. On the lateral film, 50 ml of fluid is enough to show pleural effusion, and on the PA film you need 100 ml. What about this one? So we have seen various types of pleural effusion, but all of them, they were unilateral, and pleural effusion could be unilateral or could be bilateral. Now in this case, there are 2 or 3 observations. One is that there is obliteration of costophrenic angle on both sides, right? So there is bilateral pleural effusion. And this is actually relatively small compared to the previous one. Second, I think there appears to be cardiomegaly. There is a way of actually measuring heart size, which I'm going to show you in a separate module, but this is actually appears to be cardiomegaly. And then you see these stitches, metallic stitches. This patient probably also had undergone some cardiac procedure, and cardiac failure is a fairly common cause of bilateral pleural effusion. So I think this may be a bilateral pleural effusion, right? So the etiology of bilateral pleural effusion is different. So in this case, tuberculosis is not the most likely. Malignancy is also not the most likely. I think most likely causes of bilateral pleural effusions are heart failure, nephrotic syndrome, cirrhosis, hyperproteinemia, some autoimmune disorders. So we should consider those things. So bilateral pleural effusion. It's the same bilateral pleural effusion, but this much is slightly bigger. And there another observation also. See, there is bilateral obliteration of costophrenic angle. You don't see diaphragm on either side. You don't see cardiophrenic angle on either side. You don't actually see the normal heart because both right and left cardiac borders are obliterated by the effusion. And there's something else also. Let me see if you can figure out. Well, this X-ray is basically here for pleural effusion, but there is an observation. See this part, there's some soft tissue opacity here. If you see this part, this is the line. I'm not sure if you can also see, because I am seeing in the bigger computer screen. You are probably watching it on a small device, but there is an opacity here. So I think that is to be noted. Could be common etiology, tuberculosis, malignancy, lymphoma, or something like that. So this covers our X-ray part, but I told you there is another technique of picking up pleural effusion, and that is ultrasound. You know, ultrasound has come up as a very useful investigation. It has got a relatively limited application on chest, but one of them is actually detection of small pleural effusion, and also detection of encysted effusion, and also finding the exact point where you should put your needle if you want to tap it. That way you will cause minimum trauma to the patient, because you will go straight to the floor. So let's see what an ultrasound can show in the case of pleural effusion. So this is an ultrasonographic image, and if you know, the transducer is somewhere here. You know, it is the transducer. This side is where my cursor is abdominal side. The transducer is somewhere here. It is seeing liver, spleen. This is spleen. This must be the left side. So spleen and left kidney. And then this is the diaphragm, left diaphragm covering spleen, which is the normal structure. But above diaphragm, there is a translucency, this black shadow, a crescent-like black shadow, and this whole thing. This is diaphragm, and this crescent-like black shadow is pleural effusion. And this is compressed lung. If there is pleural effusion, it has to push the lungs little up, and that will be compressed. So that is why the lung is also visible slightly dense. Now please note down, this is an ultrasound. In X-rays, all pleural effusions were white in color. Here is actually a black in color. So there is a difference, because this is actually compared to the normal gray structure of spleen. So even small amount of effusion can be detected on ultrasound. Even better is CT scan, and let's briefly examine the CT scan also. So this is the CT scan. In CT scan, patient usually lies flat on his back. So this is the most dependent part, and I think there should be no difficulty appreciating that there is bilateral pleural effusion. This is this thing. This is pleural border. There's big opacity on this side, and this is right-sided pleural effusion, and this is left-sided pleural effusion. This is left-sided pleural effusion. How do I know this is left or this is right? I think you need little experience. And one way of telling is that this is aorta. This one is aorta and it is passing on the left side. So this is left side, this is the right side, and the pleural effusion, bilateral pleural effusion. Excuse me if I'm wrong, but there is a bilateral pleural effusion. This is normal heart vessels. So CT scan can show pleural effusion in greater detail as compared to X-ray. CT scan pleural effusion further, I think one particular utility of CT scan in pleural effusion is, I think there are two conditions. I like to highlight two situations where CT scan would be considered must. Mostly we diagnose pleural effusion on simple X-ray, but there are two conditions where CT scan should be considered must. One is when we have encysted effusion, and the second one is when we suspect some underlying cause. Like if there is a effusion and we want to rule out underlying malignancy, so CT should be definitely better. This is the film X-ray chest showing encysted effusion. You see gradually lifted up pleura going up, and this is an oval shape opacity in contact with the lateral chest wall. So this is how it is seen on X-ray. Here you can see it better, and you can see thin pleura. It is actually slightly thicker than normal. There is maybe some inflammation, but then it is filled with fluid. This whole thing is fluid. From its appearance, we can tell that this is fluid. This is not a solid structure, and it is not air also. This is actually lung window, and this is pleural fluid. Okay, so picture is much more clear. Similarly here, and this is the axial section, and this is a sagittal section. You see, this is typical pleural effusion. So CT scan can play a very, very important role. I told you two situations where CT scan is of great value in pleural effusion. One is encysted, I just showed you, and the second one is when you suspect an underlying malignancy. Now this is the example. This patient has got large effusion. All the classical features of pleural effusion are there, and then you see the shift of midline also, trachea coming down, but here it is deviated to the right, it is pushed, and the heart border is also pushed to the right. So large pleural effusion with shift of midline structure to the opposite side, and trachea here is also slightly to the right side, but we don't see anything else. This is just large pleural effusion. There is a possibility of malignancy, but we're not sure. Now if we do the CT scan, that this whole thing and this whole thing I'm showing you, this is fluid, and this is collapsed lung, because when fluid accumulates, lung has to go somewhere. It comes to the hilar side and takes up this shape. It is slightly thicker than, denser than normal, because it is not, doesn't have any air, and this are the normal vessels. And if you see these small, this white and these multiple white, they are all lymph nodes. So this patient has got pleural effusion with underlying lymphadenopathy. So that should give you the clue. Now of course this could be again tuberculosis or malignancy, but in some cases there could be just one big mass. Let me see if I can find an image with a large mass with pleural effusion. Now this summarizes the radiological signs of pleural effusion. We have seen all of them, but just for you to memorize, and if you have to attempt an essay question, I think you need to know. Let me go through them one by one. Homogeneous dense opacity in the dependent part of one or both lungs with classical upper border. This is one feature. Obliteration of costophrenic and cardiophrenic angles. Another important feature, lack of demarcation of diaphragm and cardiac border, because fluid is in actual contact with the diaphragm and the heart, and X-rays would not be able to differentiate between two, and so you don't see these borders. Push of midline structure to the opposite side, and this will happen only if you have large effusion or if there is some other mass under the pleural effusion. then there are various types. So now briefly, this is not a clinical module, but just briefly, common causes of unilateral and bilateral pleural effusion. On the unilateral, I think first thing we always consider is tuberculosis, especially in our country, because that remains the commonest cause of unilateral pleural effusion. Then malignancy, any malignancy, it could be malignancy of lung or breast or some other tissue. Pneumonia followed by parapneumonic effusion. And pleuritis is a viral infection. It used to be called pleurisy, but we know it is inflammation of pleura, and there may be small effusion, unilateral. And on the bilateral side, cardiac failure, in my understanding, is the commonest cause, or at least the most important cause, and you don't want to miss it because it indicates a potentially serious condition. Nephrotic syndrome or any other cause of hypoproteinemia, there is drop in oncotic pressure, and there is a leakage of fluid into the pleural space. By the way, in my lecture on pleural effusion, which I'm going to attach with this module, there will be mechanism that will explain how the fluid accumulates. Cirrhosis of the liver, and then hypoproteinemia due to any cause, and connective tissue disorder. In connective tissue disorder, you could have unilateral or bilateral effusion. So that completes the module on X-ray on pleural effusion. But I did mention the role of ultrasound and CT when needed. These are relatively newer techniques. They must be used when appropriate. Thank you very much. This has been Professor Aziz-ur-Rehman from Medurstand. I'm going to leave the channel address in the description box. Please consider joining my channel Medurstand for many lectures like this. Thank you.